Great. Okay, good morning, everybody. Welcome to PAME. This room is really long and deep. So feel free to get out your binoculars if you're sitting back there, or come on up. There are a lot more seats up front. So anyway, welcome. I am Gardner Lapham, and I have the pleasure of welcoming you to the 8th ever in-person PAME conference. And I know it's probably a funny number to recognize, but it's pretty remarkable, I think, that this collaboration has been going for as long as it has to end premature epilepsy-related mortality. And I'm so glad that we're still doing this because, as we know, people living with epilepsy are still 3 times more likely to die early than the general population. So I'm really humbled by everybody's commitment and want to thank each and every one of you for being here today and working so hard to realize a world for people living with epilepsy, a better world. And I'm going to be a little cheesy, but here we are in Orlando, and I think let's all channel the spirit of the Magic Kingdom and work to realize our dream of ending all worries and risks associated with seizures. So as many of you know, As many of you know, PAME began in 2012 with the goal of bringing different stakeholders together to learn from one another. At that first meeting in Evanston, Illinois, we welcomed researchers, clinicians, nonprofit leaders, medical examiners, international experts, pharma representatives, NIH and CDC experts, people living with epilepsy and their caregivers, and of course, bereaved family members. It was a powerful gathering of people with different experiences and skill sets, but a common desire to better understand epilepsy mortality and how to prevent it. You can see here how the conference has witnessed steady growth over time, and I'm so thrilled to see the room full today. So out of curiosity, I want to see a show of hands of how many people have been to this meeting before. Oh, wow, that's a big group. How about who's new? Oh, it's a big group too. Okay, welcome especially to the new people, and thank you to the people who've been here before for returning. So ever since its founding, the PAME conference has been organized and led by volunteers that represent our different stakeholder groups here. So sitting up here today are the organizers of this year's conference, and I'd like for them to introduce themselves and maybe just say a little thing as to how this meeting is meaningful to your stakeholder group. George?
Working? Yeah. Welcome, everybody. So I'm George Richardson. I'm chairman of neurology at University of Iowa, which happens to now be a hotbed of SUDEP research with a lot of people interested in that topic. And I'm representing basic scientists and clinical researchers. So I do both and work mostly with mice. And what does this meeting mean to me? I've been to all of them, and it's been really very rewarding to be part of this group. And I think the reason it's been helpful for me is encapsulated with an interaction I had with Gardner last night. So she asked me how my research was going, and I started telling her about some new animal work that we're doing that I'm really excited about. And then she interrupted me and she said, yeah, but how does this translate to care of patients? And that's what this meeting does. It makes us think about that. And it does it just because that's what the goal of the meeting is, but also because of our interactions with each of you. And people want to know how this is going to help them, and it makes us think about how we can do that. So with that, I have a couple pieces of business. So in the afternoon, I guess at lunch, we have a networking session for trainees who want to talk to people who are practicing researchers, and you can have lunch with them and ask them basically any question you want about your career or science. And then we have a poster session at 5 o'clock, 5 to 6:30. And I encourage everybody to go, including the people that are not scientists, especially the people that are not scientists, because this is an opportunity for you to ask questions one-on-one with people who are doing research to really get to understand it better and to know why we're doing it and maybe give us ideas on what we should do differently. So, and then lastly, Elizabeth and I are going to be doing a walking tour at the AES meeting on Saturday at 1 o'clock for SUDEP posters. So we encourage you to join us for that. So with that, enjoy the meeting and thank you for coming.
Good morning, I'm Ann Gramiak, and I'm the Senior Manager of the Epilepsy Leadership Council and Partnerships at the American Epilepsy Society. I'm very proud to work at AES and support PAME. AES is also very excited to be part of PAME from the beginning, going as far back as a task force and the committee I think Jeff told us about a few PAMEs ago. Myself, I'm a public health person, and I appreciate being part of this effort just in terms of raising awareness and of working on addressing the risks of SUDEP and how people can hopefully protect themselves and their loved ones. And I know AES very much values the relationship with PAME and supporting this meeting. So thank you all for being here.
Good morning, everybody. I'm Jeff Buck. Is it on?
Push the button. It doesn't light up, but it works.
Maybe it's just for me.
It works. Try talking.
Testing 1, 2, 3.
Yeah.
I'm on. I'm Jeff Buck-Aldro, a clinical pediatric neurologist, epileptologist, and you know the meaning to me, and I think my community, which is all of you, is the nature of this meeting. PAME was conceived as a forum for bringing people with epilepsy, the bereaved, clinical and basic scientists, advocacy organizations, industry, regulatory agencies together in one place to share knowledge. And when you think about all the meetings that we go to, at least in my mind, this is fairly unique to have this kind of interchange of information by and for and in the presence of those that are most affected by premature mortality. So I think we can all share in this, and it's just so wonderful to see all the hands that went up for folks that haven't been here before. We have return visits, and we have our news today, and it's been really terrific. So I'm looking forward to the day, and thank you for coming.
Good morning. My name is Elizabeth Donner, and I lead the Division of Neurology at the Hospital for Sick Children in Toronto, Canada. And I know we have some other Canadians here, so come and find me, please. I've been involved with PAME from its inception, and as someone who works with people with epilepsy and does research in this space, really PAME has meant watching people make those connections. It's very exciting for me to see what George described, which is scientists come up to me and say, thank you for the meeting because I've never met someone with epilepsy before, let alone someone who's bereaved by SUDEP, and how meaningful that is. But also for me personally, the relationships that I've built, the collaborations I've built have really been instrumental in my career and my life, and so I'm just grateful for PAME.
Good morning. I'm Tom Stanton with Danny Did Foundation, which is based in Chicago, and I'm a part of the planning committee to represent people with epilepsy and caregivers in particular. I think back to the first PAME meeting in 2012, just outside Chicago. My nephew had just passed away a few years prior to that, and we were just finding our way kind of as a new organization in the space. And so PAME was a revelation to me that there was scientists and doctors and advocates who cared about what we cared about, who were studying it, and who wanted to prevent death in epilepsy. I didn't know that before. I think a special aspect to the PAME meeting is that it provides a chance for people with epilepsy and caregivers, parents, to kind of go behind the scenes and see what's happening. We don't get that chance very often in our patient and caregiver community, so I think PAME is really special that way. Attending PAME was also the first time that I had been in person with other families who had experienced a loss similar to ours. So I think that's a really unique and special part about this meeting, is that we get to come together and meet each other. We did that yesterday at Family Day, and I just want to thank, again, Mary Duffy and Allison Kukla for their leadership, and to commend everybody who was there for your courage to attend, and so many of you sharing your stories. That was a really, I think, special way to start the meeting. I never want to meet a new family at PAME, but I will say that many of the families I've met here have become lifelong friends, and I think, as Dr. Buckhalter alluded to, you know, we get to know each other across our different communities, and I think knowing each other and caring for each other is the reason why we're still in this arena after many years, and that's important. So thank you, Gardner, for leading our charge, and I'm excited for a good day. Welcome.
Thank you all. Can we clap for these guys? I mean, as you can see, they work so hard, and they've become great friends, and I'm grateful to all of you. But I really need to especially call out Anne, who is the invaluable driver of this whole meeting today. And we literally would not be here without Anne and her incredible attention to detail and her overall leadership. So thank you very much, Anne. And as Tom alluded to, we had the Family Day yesterday, and this is really an exciting new addition to the PAME effort. So yesterday was the second ever family gathering, and I want to again thank Mary Duffy from the Danny Did Foundation and Allison Kukla from the Epilepsy Foundation for organizing yesterday's meeting. It was just another powerful convening of families gathering together to support one another and learn from those who've turned their grief into action. So thanks to everyone for yesterday. And so the conference is not all we do anymore. I'm pleased to say that not only has this conference grown, but so has PAME's influence. While the mission remains the same, which is to convene, educate, and inspire all stakeholders to promote understanding and drive prevention of epilepsy-related mortality, the partnership has found new ways to expand its reach. So in addition to this conference, we now facilitate committee work around issues of importance and foster collaborations between nonprofit partners. So we also funded our first ever early career grantee in partnership with AES. And so I want to congratulate Dr. Del Ponzo Sands. He's not here, but I know he has a poster on Saturday. And for those of you interested in applying for next year's awards, please look at the AES website, and those applications are due by January 18th. So PAME has been pleased to host a number of webinars, and this is a sampling of this past year's topics that range from common SUDEP misconceptions to the global burden of epilepsy mortality to epilepsy surgery and long-term survival, to focus on family-led organizations and their role in SUDEP prevention. I really want to call out these industry partners for supporting the webinars this year. Thank you. And there's so many people always to thank at this meeting. I'm not done yet. It truly takes a village for this meeting to happen. And in addition to those who I've already mentioned, I'd like to thank all of the people who participate on PAME's various committees, including the SUDEP Research and Prevention Committee, the SUDEP Legislative Task Force, the Community Outreach Committee, the PAME Leadership Committee, and the Abstract Review Committee. Wave your hands or stand up if you guys are part of all of that. There's way too many people to announce my names, but thank you. so much. So we're grateful for their dedication and willingness to serve this mission. And we welcome newcomers to this effort. So if anyone's interested in joining any of this stuff, please contact me or Ann. And I also want to thank the organizations who support PAME. First and foremost, thanks to the founding organizations, Cure Epilepsy, the Epilepsy Foundation, and Danny Did. And a very special thanks goes to AES, because AES serves as our fiscal sponsor and provides extremely generous in-kind assistance in meeting planning and logistical support. So thank you, AES. And I want to thank all the other nonprofit, foundation, and industry supporters. Not only your financial support, but also really your thought leadership are critical to ensuring the success of this meeting. So thank you. I love that we have such a range of partners, and I believe that we're all stronger in what we do because we're doing this together rather than alone. Okay, and in addition to thanking this year's amazing group of conference faculty, which you will get to know over the course of today, I want to thank the poster presenters. As George mentioned, we have nearly 50 investigators this year sharing their work, and that will be this evening immediately after the conference. Next door, there'll be a reception and all their posters. So please join this evening. And then I was told if you didn't get a drink ticket, to pick up a drink ticket at the registration. So that's for people who registered yesterday. And then last but certainly not least, I want to thank the families for being here. I know firsthand that it's not easy to attend this meeting. Having lost my son to SUDEP 15 years ago, I still find this meeting difficult. For many, it will be hard because it will stir up memories and complex feelings of those who we've lost. And for others, for people living with epilepsy and their caregivers, this meeting will be hard because it lays bare the true risks of living with epilepsy. But I invite all of you who are struggling to join me in finding the hope that this meeting offers and to know that together we're making a difference for people with epilepsy. And I invite everyone to please spend time at the virtual memory wall, which is down there. Find time in so please spend time at the virtual memory wall and honor those who have died. Let's find inspiration in these beautiful lives and recommit to our hard work ahead. Okay, some housekeeping. First, for those attending the Science Networking Lunch, as George talked about, it is, after lunchtime, grab your plates, and it's Ballroom E, which is around the corner here. Jeff and George will be the main point people for that. Second, we have worked in very hard Q&A time. Please ask questions. Please keep them broad and not specific to an individual, but we really want to hear lots of questions. Please meet somebody new today. Purple tags are family advocates, nonprofit professionals. Green lanyards are professionals. Just go up and introduce yourselves. Everyone here has a really interesting story of why they're here. So I hope you get to know new people. And let's see. The evaluation, super important. We actually pay a lot of attention to the evaluations. We want to know how this year went for you all, but we also really want new ideas for next year. So, and then the families. This meeting, as we've said, is tough. If you need to leave, leave. And go take a break. And there is a family breakout lounge upstairs, 235 is the room, right? It's a little bit of a walk, Ann tells me, but you can relax in there. Oh, and if you need a key, so you go to registration and you can get a key there. There's also just plenty of space, but feel free to come and go is more the point. Okay, now it's my pleasure to turn the podium over to Elizabeth, who will announce our keynote speaker for the day. It's the family room. There we go.
Good morning again, and thank you, Gardner. Gardner, you mentioned turning grief into action, and there is nobody I know who has done that with more strength than you. And I stand in awe of that, and I can't get up here after you and not acknowledge that, so thank you. It's my absolute pleasure this morning to introduce, but just so happy to have her here with us, Professor Helen Cross. I really don't think that Professor Cross needs an introduction, but I'll do it anyways. She is the Prince of Wales Chair of Childhood Epilepsy at UCL Great Ormond Street, and also the director of the UCL Great Ormond Street Institute of Child Health. And certainly for as long as I can remember, Helen has been an international leader in epilepsy. And as a epileptologist and a pediatric neurologist, she has done so much pivotal work in things that that impact how I take care of children every day. Cannabis, ketogenic diet, surgery, I don't know, I have a list, genetics, the list goes on and on. Currently, she is the president of the International League Against Epilepsy, and we're so pleased to have her here this morning to really talk to us about what the international community is doing to address mortality and epilepsy, where the gaps are, and I think probably some solutions as well. So Helen, please come up and share with us your talk.
Bit of a hazard up here. We could have all been in A&E. Anyway, thank you so much, Elizabeth, for that kind introduction, and thank you to the organising committee for having asked me to come and speak. It's an absolute honour to speak to this audience. I, as Elizabeth has indicated, am a paediatric neurologist by day, and that's my day job. I've always been involved in trying to improve the outcomes of particularly children with early onset complex epilepsy. And so, unfortunately, the topic of today has been so, very real on a day-to-day basis. So thank you for asking me to speak. But I'm standing here really in my other role as the president of the International League Against Epilepsy to talk a little bit about how we're trying to move forward improving services for those worldwide, not least to reduce, as one of those primary aims, mortality from epilepsy. The International League Against, I'll just start with my disclosures. So the International League Against Epilepsy is the global organisation responsible for the professionals worldwide who care for those with epilepsy. And we work in partnership with the global organisation for the patients' organisations, not least the International Bureau for Epilepsy. And we've long had a history, and I apologise that some of the writing on these slides may be a little small for those in the back, but I will go through the pertinent points. But this is just a timeline of key initiatives that we have undertaken with the IBE, the International Bureau, and with the World Health Organization in trying to raise awareness amongst those who fund services for epilepsy worldwide in different regions, different initiatives to try and highlight the issues, not least starting with the formation of the Global Campaign Against Epilepsy in 1997, which really was a tripartite initiative between the ILAE, the IBE, and the WHO. And since then, there have been many regional declarations about the need to do more for those with epilepsy. There have been the demonstration projects, which are projects whereby individual countries co-funded with ministries of health, demonstration projects that if you improve services and medication availability, then you do improve care with a degree of sustainability in the long term. And there's a big project in China, a big project in Brazil, as well as other countries around the world. And then I move forward to look at initiatives in parallel, not least mental health initiatives, the Atlas on care for those with neurological disorders, which highlighted the shortage of specialist care around the world. And then most recently, a report that was published in 2019 between the three organizations, Epilepsy, a Public Health Imperative, to really outline that in order to move epilepsy care forward globally, not just in certain countries of the world, it needed to be looked at holistically, and there really needed to be a commitment on behalf of healthcare systems. So this led in 2020 to the commitment from the World Health Assembly. So that is the annual assembly of the World Health Organization, where all member states are representatives, and then there are 192, where there was overall agreement that there should be a move forward towards intersectoral global action plan on epilepsy. There was agreement that there needed to be a move forward to this 10-year global action plan, which we needed to look at not only epilepsy, but other neurological disorders. We accepted that. But it needed to address multiple gaps and inclusion needs, the need for research, further research and funding for research, an ability to assess progress, and also the creation of a technical report on epilepsy alongside this. And in May 2022, the draft intersectoral global action plan was indeed approved. Again, this was commitment from all 192 member states of the World Health Organization on an intersectoral action plan for epilepsy and other neurological disorders. And the full finished product was published towards the end of last year and is available to download from the website, the WHO website. So what is this? Well, as I said, it is a 10-year plan, and this by agreement from all 192 member states of the World Health Assembly means they have signed up to the delivery of this global action plan. Alongside this, as was requested, there has been an epilepsy technical brief, which was again published at the end of last year. And this gives an example of how there can be, giving examples of how individual member states and indeed ministers of health and individuals can move forward in trying to lever action and also provide tools for change. What we see this as, it doesn't come with money, as does anything when we create this, but it can be used as a key to unlock the discussion with ministers of health, unlock political momentum. It has 5 strategic objectives, 4 in general for neurological disorders, and the final one, number 5, is specific to epilepsy. And within that, 10 targets, which member states have committed to achieve by the end of the 10 years, with a review 5 years in. So if we look at it at a glance, it basically looks at and states up front that it's looking at a vision of a world in which brain health is valued, promoted, and protected across the life course. That neurological disorders are prevented, diagnosed, and treated, and premature mortality and morbidity are indeed avoided. And that people affected by neurological disorders and their carers attain the highest possible level of health with equal rights, opportunities, respect, and autonomy. There are 2 specific goals: to reduce the stigma, impact, and burden of neurological disorders, including associated mortality, morbidity, and disability, and to improve the quality of life of people with neurological disorders, their carers, and families. There are a set of 6 guiding principles, not least looking at a patient-centered approach, looking at a universal healthcare approach, and indeed looking at empowerment and involvement of persons with epilepsy. But also then the 5 strategic objectives: to raise the prioritization and strengthen governance, to provide effective, timely, and responsive diagnosis, treatment, and care of neurological disorders, to improve strategies for promotion and prevention, to foster research and innovation and strengthen information systems, and the final one, number 5, to strengthen the public health approach to epilepsy. And here are the 10 global targets. As I said, 5 objectives, 10 targets within that, and what they mean for epilepsy. But essentially, they are targeted at 3 predominant areas: closing the treatment gap, closing the inclusion gap, and closing the research gap. And I often have a comment about how can you get 100% increase in research? Well, essentially what that means for each country is doubling what they do. So in resource-rich countries, it may be perceived that already quite a lot of research goes on. In resource-poor countries, there's very little, but even just doubling it would be a major step forward. And of course, there are supporting targets as well, looking at national plans and strategies, epilepsy-related indicators, and intersectoral brain health promotion and prevention. So how will this benefit us understanding mortality in epilepsy? And how will it move us forward? Well, if we look at particularly, and I'm looking at a global point of view, this is a map highlighting the prevalence as we know it from the global burden of disease data of epilepsy worldwide. And what this highlighted, and this was published in 2016, is that 80% of those living with epilepsy reside in lower and middle income countries. Now, we've all raised a bit of an issue with the global burden of disease data, not least because they class epilepsy on the part of what they're measuring as idiopathic epilepsy. And what we mean by that is it's only individuals with epilepsy alone. So those individuals that have epilepsy as a result of other disorders would be classed as those other disorders, not necessarily epilepsy. So whatever has been determined here has probably been an underestimate of the problem. Even so, it's still the fifth greatest burden of disease for neurological disease worldwide. And we're trying to address that with getting more accurate data. But also looking at the mortality, and this is actually looking, again, from the same data at the mortality worldwide. And you can see actually the greatest percentage of mortality has been registered as in low and middle income countries, again, where 80% of those with epilepsy reside. And although, again, they report a reduction in mortality rate over a period of time, it's probably greatest reduction in the lower middle income countries, which may be a result of some of the underlying causes, such as head injury, perinatal or birth injury. But even so, with this estimates of numbers, it's still relatively high. And this, again, I just highlight because I know that the writing's small, but this actually looked at a prospective study in Kenya, one of the resource-poor countries, perhaps, and it looked at hospital admissions, the result of epilepsy, and looked prospectively at, it was a prospective study following 754 individuals with convulsive epilepsy, and they found 61 deaths in that time. That wasn't only from hospital admissions, but 61 deaths. And you can see actually those most at risk from death were actually the older population. But what I wanted to highlight and 56% of deaths were directly related to the epilepsy. Prolonged seizures or status epilepticus, continuing seizures in 38%, a proportion of which may well have been SUDEP in their analysis, and absolute SUDEP as they recognized it in 7%. But what they teased out from this, and the reason I highlight this study, is not only did they find that the death was related to age, the risk of death was related to age, it was also related to cognitive impairment or learning disability, but also what they classed as adherence to medication. And if there was a history of not taking the medication on a regular basis, or indeed from medication levels, drug levels in the blood, the risk was much higher for mortality than if there was a history that they'd taken medication on a regular basis. And this, I have to say, is not only, it's not, they call it adherence, namely with regard to are they remembering to take the medication, but as I'll come to, in resource-poor settings, is there a continuing supply or indeed an understanding that they need to take it on a regular basis? So how can we move forward with this? Because it's a case of the fact that there is a relatively high mortality rate wherever you look, and how can we move forward with perhaps utilizing this global action plan to resolve or even move forward in this issue? Well, certainly we need to move forward with regard to the treatment gap. We need to raise awareness of epilepsy as a treatable condition. So many in this room might think, well, surely that's straightforward. But no, the lack of understanding in many of the resource poor settings and with the cultural beliefs is that epilepsy is contagious, the stigma that rises from it. They don't seek help because they don't understand it as a treatable condition. The access to appropriately trained healthcare workers. Access to medicines. It's not so freely available in many settings. Access to diagnostic technologies, EEGs, brain scanning, let alone the more complex genetic testing that we now talk about. And access to specialist services. And how will this move us forward? Well, certainly we can look at the role of specialist care reducing mortality. And this table is a table taken from a paper that we published from data in the United Kingdom, where we took data from our national audit, looking at two specific points in time. We have a national audit of children presenting with epilepsy, where they're all registered from every district hospital and followed up at 12 months. And we look at a set of 12 indicators as to how the service is doing. And part of that is, do they have the appropriate referral to specialist care? And then that was compared to the hospital the National Registry of Death Statistics, so that we could see any correlation between access to care and indeed the mortality. And what we found was that if you compared those that were eligible to see a pediatric neurologist against those that were not, those where we compared units, if they saw a specialist or were within specialist care in childhood, their risk of mortality in early adulthood was markedly reduced. Now that is significant. And this is something that's also been seen from Canadian data with regard to adult care. And you can see these three lines here. This is death rates unexposed to neurologist care. This where they're exposed to neurologist care, and this where they're exposed to a comprehensive epilepsy program. So specialist care matters, whether you're an adult or whether you're a child. But the specialist care isn't necessarily available. And this is data from the Atlas of country resources for neurological disorders. And essentially, whether you look per country or whether you look per resource setting, certainly low-income settings, there is a very minimal number of neurologists per 100,000 population. And even then, in high-income countries, it's not necessarily optimal. And actually, if we then look at where the care is probably, this is looking at healthcare professionals that may be involved in those with neurological disorders. And yes, that's more evenly spread, whether you look per country or indeed per income country, but it's not necessarily specialist care. And this was again emphasized more recently with this survey, which was undertaken by the International Child Neurology Association, where they undertook a survey worldwide of numbers of pediatric neurologists and produced this interesting map here showing the fact that the orange and red is where there's really minimal pediatric neurology care available for treatment of children. And again, showing here whether, according to region, Africa here, North America, Europe, Latin America. And essentially, this is actually the numbers of pediatric neurologists, and this the numbers of child neurologists per 100,000 population. And you can see it's not, Europe may be seen to be actually relatively good. It's still not great if you look at an individual country level. And then we come to availability of medication. We all take it for granted pretty much, probably in many high-income countries. But this was a survey that the International League Against Epilepsy undertook with regard to access to treatment and was published in 2021. And essentially, this is access to first-line medication, to access to at least one medication, with the list of the individual medications down the side here. So the top one is access to at least one medication. And you can see blue is actually lower and middle income countries. Or no, blue is actually access, and you can see that they predominantly do have access. But then when it comes to other medication, second line medication or a third medication, it really drops off. That really is not available worldwide. And indeed, when it comes to treatment of status epilepticus, this is what this chart shows. The purple, the sort of brown color is the availability in resource-poor countries. You can see it's very limited. Even benzodiazepines that we take for granted, like midazolam, like diazepam, like clobazam, lorazepam, are actually very limited in their availability. And of course, there is the essential medicines list, which is, the WHO, the World Health Organization, produce a list of medications, not just anti-seizure medications, but other medications as well, that they feel are essential and that governments should endeavour to have within their formulary in each individual country. And this, we actually had the addition of the levetiracetam to that list in July of this year after a lot of lobbying. But that said, this actually gives data from a survey that we undertook in the International League Against Epilepsy to try and find some baseline data following the approval of the Intersectoral Global Action Plan with regard to countries worldwide as to availability. And you can see that actually the availability even of the essential medicines on the essential medicines list isn't necessarily there, because actually the target, as I'll come to, is actually 80% of at least one medication. And you can see that actually other medications aren't there. And indeed, it does depend on the region. And then again, I come to the relevance of adherence, the relevance of taking your medication on a regular basis. And there's been a lot of mixed data. What this on the right is what we call a meta-analysis, so a review of all studies looking at whether the anti-seizure medication was found in the blood following the death of individuals. And there's been a lot of mixed discussion, particularly whether this is relevant. But on the whole, there's a general feeling that not taking medication on a regular basis is a risk factor for mortality in epilepsy. But that doesn't only mean you remembering to take it, which in many settings is very difficult, but also, is there a continuous supply of medication? And I know, for example, in many countries in Africa, hospitals get a set supply, and once they run out, they have to wait till the next financial year to indeed get that medication, which isn't good news for patients. And we know also with continuing seizures that the risk for mortality, and particularly SUDEPs, is high, not least with regard to here. This is population-based studies going up to higher rates in epilepsy surgery candidates. So in those that haven't yet undergone surgery, if they're candidates for surgery. And again, this recent study looked at reviewing all the data to see whether surgery made a difference overall to mortality rates. And it didn't matter whether they looked at total mortality rate or indeed SUDEP. Certainly in those who were evaluated for surgery, so they had continuing seizures, they were evaluated for surgery, they looked at those that underwent surgery versus those that didn't undergo surgery. Surgery versus no surgery. If you had surgery, you were 2 times lower risk of death and a 3 times lower risk of SUDEP. Epilepsy surgery is not available in many countries around the world. And indeed, this final study just looks at, in fact, is what they actually did demonstrate, that it's the seizure freedom that you achieve from the surgery that contributes to that lower risk. And before I come to what we're doing about it, what about research? Well, I don't have to talk in this audience about all the research that's ongoing, but traditionally, and this data on the left is actually data from the 2019 report from the WHO, IBE, and ILAE, showing the number of papers published is relatively low in some areas of the world. And as per usual, this is epilepsy funding down at the bottom here, compared to all the other neurological disorders and some other chronic diseases. We've always the poor relation. I know there's been an increase, particularly from NIH with regard to the Centre Without Walls, etc. But we're still the relatively poor relation when it comes to funding of research. And the idea is that we should be trying to increase funding and research capability worldwide to enable greater collaboration to move forward in those key areas that we still need data on with regard to mortality and SUDEP. So, and I apologize for the formatting. How does IGAP move us forward? Well, we see the Intersectoral Global Action Plan as an unprecedented opportunity for epilepsy and neurology to unlock the doors to ministries of health and approach healthcare professionals at different levels. We can hold governments to account by monitoring progress towards agreed targets. By commitment to the Global Action Plan, they have agreed to monitor their progress against these targets, and it will be reviewed in 25 years on, so in 2027. We need to lobby to change laws, to put inclusion and rights into the spotlight, and help people to come forward to make sure that they address the fact that they have epilepsy and they can gain the right treatment. Increase funding to close treatment, inclusion and research gaps, and address psychosocial determinants and barriers to seeking healthcare. Unfortunately, we're quite a way off most of these targets. And again, this is a survey that the International League undertaken to try and get some baseline data from all countries around the world who are within our, we have access to 160 territories, 129 chapters, country chapters, and we surveyed those in order to try and find out where we are with each of these targets that have been set in the Intersectoral Global Action Plan. And you can see that in many regions, actually green means it's relatively good, and even then, it depends what you define within how you look at universal health coverage. And the fact it looks pretty good, except within Africa. And of course, actually acquiring data on where we are is relatively poor worldwide. So if we look at the strategic objectives one by one and what we can try and do, try and move forward with that and where we're at, we can look at target 1.1 is 75% of countries include epilepsy and other neurological disorders in national plans. We can utilize epilepsy as what we call an entry point, a service model that when other neurological disorders can follow. And we are producing a step-by-step manual for different countries in order to help countries develop national epilepsy plans and move forward in negotiation with their governments. And also moving towards awareness, advocacy, and we continue to work with the International Bureau for Epilepsy for International Epilepsy Day, and also the International Bureau for Epilepsy are producing an advocacy toolkit. Just to highlight where we are with national health plans, you can see that nowhere is anywhere near the target of getting incorporation into national health plans. And most regions are a long way from the awareness target that has been set within the Global Action Plan. Strategic Objective 2, an effective, timely, responsive diagnosis, treatment and care. 75% of countries include epilepsy and other neurological disorders as part of universal health coverage. You can see that's not really there yet. We can try and advocate for including it in benefit packages and reduce out-of-pocket expenditure in investment cases to show cost benefit. And looking at countries' access to essential medicines and technology, looking at landscape surveys, looking at how we can move forward in governments incorporating the essential medicines list into their pro forma, and guidance on use of generic medications. Target 3.1, 80% of countries having an intersectoral brain health promotion and prevention program. This exists in a way to looking at stroke prevention. We can look alongside other diseases to try and to see particularly those that could be prevented, they'll ultimately prevent epilepsy. 25% of epilepsies worldwide are the result of preventable causes, whether it be due to infection, whether it be due to congenital birth injury, perinatal birth injury, or whether it be due to traumatic brain injury or indeed stroke. So these are all preventable. So it's working alongside other organizations to try and prevent those. And target 3.2, looking at global prevention targets, exploring other epilepsy-specific prevention opportunities, as I've said. Objective 4, research and innovation. This is why I mentioned research earlier. 80% of countries routinely collect and report core data sets. That's really not happening. Really trying to help with trying to move that forward, and doubling the output of global research in epilepsy and neurological disorders. So that's what we mean by 100% increase, which is the target. Countries doubling what they do existently, they double their research funding for what we need to do. And yes, we're collecting, we have a gateway, which I'll come to, where you can go in on the internet, find out what projects are going on worldwide, how that can be perhaps, how individuals can help, participate, utilize similar models. We actually have a Lancet Commission, a Lancet Neurology Commission in progress, which is a document to highlight what the research priorities in epilepsy are over the next 5 to 10 years. And mortality and SUDEP are very much one section of that. And also, we, of course, continue to publish within the ILE with regard to our journals. And this just highlights again that epilepsy data is not routinely collected in different countries. And finally, strengthening the public health approach to epilepsy, increase epilepsy service coverage by 50%, 80% of countries reviewing legislation to protect the rights of people with epilepsy. There are many things that we need to do, not least understand the disparities of care and needs and gaps in services, developing integrated people-centered care pathways and service models. And this showing the epilepsy service coverage, again, variable worldwide. And indeed, we have to accept that governments are statistically more likely to be interested in expanding epilepsy services if epilepsy is included in a national health plan. Most countries do not have a plan. We have a plan within the International League Against Epilepsy with helping chapters, providing resources. We have the acronym EPIACT, engagement plans, information, access, care pathways, training and education. Care pathways, we're trying to produce a standard care pathway that can be applied in any setting. Training education is core to what we do. We have a gateway which has 3 portals, our academy for training professionals. We also have much regional training going on, the portal to the database of projects, and a portal to a manual to help countries, chapters, facilitate local discussions, local projects. And so overall, we're aiming to close the treatment gap. With the International Global Action Plan, 100% of countries, 192 countries, committed to implementation. So they committed to achieving data on all epilepsy services and incorporating epilepsy and other neurological disorders into healthcare plans and budgets. We are really aiming for our 2031 31 target, not 21, 31 target, 70, 80, 90. 70% of those treated achieving adequate seizure control. That's achievable if they get the right medications. 80% of people with epilepsy having access to the appropriate, affordable, safe anti-seizure medications. And 90% of people with epilepsy being aware of their diagnosis as a treatable brain disorder. We are determined to get there. Thanks very much.
That was amazing. Okay, so we don't really have time for questions. However, can I ask you one question? What can we do here? How can people in higher income countries, whether it's the lay public or the professionals sitting here, how can we engage and help? You mentioned the gateways, which is interesting, but would love to hear your thoughts on that.
Put on the spot.
Yeah.
I think we all recognize that it doesn't matter where you live, services are not optimal throughout. And it's all very well if you live local to a comprehensive epilepsy program, but there are many areas that don't. And I know that in my own country, and it's a lot smaller than North America. We have different healthcare systems. So in a way, advocating and lobbying is one of the two ways that can be. Find out who may be locally interested in this, looking at public health pathways in order to gain entry into this. And I think this is the real way forward. The patient voice, I have to say, is the loudest and what is listened to. When we professionals go to the government and they just think we're bleating on about our specialty. whereas those with lived experience have a real power. So working in partnership and working with your local professional services, looking to advocate for services is what needs to happen.
Great. Thank you so much, Dr. Cross. That was amazing. And we have a little present for you down there, which I will hand to you later. Okay, now going to welcome up to kick off our first plenary of the day, and I have the pleasure of introducing Dr. Dan Friedman. So Dr. Friedman is from NYU, and he is an associate director of the Comprehensive Epilepsy Center there and co-director of the Video EEG Lab at NYU. He sees adults, and Dan does a lot of things, but I'll just focus on what you do for mortality and morbidity research. And I've known Dan for a while now, and he has really emerged as a real leader in the SUDEP space. And I'm thrilled because you're actually not focusing on SUDEP this morning, and Dan is forcing us to think much more broadly about epilepsy-related mortality. And so anyway, it's an honor. Dan's going to come up here and kick off the session. And I should also say Dan co-chairs the SUDEP Research and Prevention Committee for PAME, so I'm grateful for that too. Thank you, Dan.
Actually, I just do whatever Gardner asks me to do. That's so. Thank you, and thank you to the organizers, and thank you for the invitation, and thank you for putting this topic at the start of the meeting. I think I've been to every PAME meeting, and while it was nice when PAME was a freestanding meeting with a lot of time for discussion and socializing and networking, I actually really enjoy the fact that this pre-meeting kicks off the AAS meeting now, because listening to the stories of the families, the advocates, really focuses the next few days of the scientific meeting. It makes me want to absorb as much as I can to improve the lives of our patients. So as a way of introduction to the session, and as Professor Cross mentioned, epilepsy is a significant contributor to premature mortality worldwide. And it's estimated that compared to the general population, people with epilepsy have a 2 to 4 fold increased risk of mortality. And that means that when you count the number of deaths in people with epilepsy compared to what is expected for each different age group, that number has increased significantly. A lot of those deaths are due to the underlying cause of the epilepsy, but even in people who have no known cause for the epilepsy, sometimes called idiopathic epilepsy, their life expectancy is reduced. And that reduction in life expectancy, that increased mortality, varies across the lifespan. On this side, we have pooled data from studies, epidemiological studies in high-income countries, where we could see the standardized mortality ratio here, the age on the x-axis, and children and young adults have a 7 to 8 times increased risk of death compared to the general population, because in those countries, in those settings, children and young adults aren't supposed to die. But increased mortality related to epilepsy remains elevated across the lifespan. When we look over here, this is the data from low and middle income countries. And in this country, even that we know that the rates of childhood death is much higher than developed countries, the rates of premature death due to epilepsy are even higher in in kids, up to 100-fold in one study from China. So what does that mean? Most of the excess mortality due to epilepsy is among children and young adults. And even in older age, there's excess mortality. But what it really means is the public health burden of epilepsy is huge, and there are many, many potential life years lost to epilepsy worldwide. And not only that, but that public health impact is not distributed evenly across the world, as Professor Cross mentioned. So why do people die with epilepsy? Well, for a lot of cases, it's the underlying cause of the epilepsy. I mean, whether it's seizures due to brain tumors or metastatic tumors that go to the brain, neurodegenerative diseases of childhood or adulthood, genetic disorders, etc. Sometimes it's due to the epilepsy itself and its treatment. So epilepsy is, while seizures are the most prominent manifestation of epilepsy, epilepsy is a disorder of brain circuitry, and there may be other comorbid diseases of the brain, including psychiatric diseases, which lead to increased rates of suicide among people with epilepsy. Our treatments aren't entirely benign as well. People have adverse reactions to drugs that we use to treat epilepsy, both in the short-term, immediate allergic reactions, as well as long-term reactions. Our medications cause side effects, which can lead to falls and which can lead to fatal injuries as well. And then there are seizures themselves. Seizure-related death include, we think, most of the SUDEPs that affect our people with epilepsy, but also can lead to deaths due to accidents, drownings, prolonged seizures, status epilepticus, and aspiration pneumonia. And these non-SUDEP deaths, which will be the topic of this session, account for about half the deaths related to epilepsy in cohorts with long-standing disease. Now, the good news, and the speakers in the session will highlight, is that if we identify, screen, and intervene, we could potentially prevent some of these causes of premature mortality. So we have a great lineup of speakers today. The first speaker will be our family speaker, and that's Kelly Cervantes, who spoke yesterday at the Family Day as well. But she's an author and advocate, former Cure Epilepsy board director, and she will discuss how all these factors that I mentioned were related to the tragic premature death of her daughter, Adelaide. I'll speak about specifically seizure-related mortality, excluding SUDEP, including accidents, drownings, and status epilepticus. Dr. Leah Blank from the Icahn School of Medicine at Mount Sinai, also in New York, will talk about comorbidities in adults and how they contribute to premature mortality in epilepsy. Dr. Donner from Toronto Sick Kids will speak about comorbidities in children and how they contribute to early death in children. And then finally, Dr. Colin Josephson from the University of Calgary will discuss long-term risks of epilepsy treatment, and specifically cardiovascular risks of medications, among other things. So with that, I'd like to bring Kelly up to the stage.
Thank you so much. So my daughter Adelaide was born in October of 2015. The regular story here, typical pregnancy, healthy birth, nothing to raise alarms, but she we quickly realized that she had low muscle tone. Got her to a neurologist. By the time she was 7 months, she'd had her first seizure. 2 months later, it was infantile spasms. Any progress that she had made, hold on, where's our clicker here? Oh, yeah, all good.
My slides.
Oh,
Can we just switch to?
do we have those? It's okay. Now I've lost my thought. Oh, thank you. Any progress she had made, even by the time she was about 9 months old, she had progressed, I would say, to about a 3-month-old, so still significant delays, but she was making progress. As soon as infantile spasms entered the picture, everything was lost. Over the course of the 4 short years of her life, we lost her laugh, we lost her smile, we lost any progress that she had made physically, holding her head, sitting up, all at the hands of her seizures. Every time we would get control of her seizures, we would see progress. We would see her start to develop. Unfortunately, we never got more than 3 months of seizure freedom. So every time we tried a new drug, a diet, a treatment, we would immediately see the seizures come back, and with that, the regressions. Now, I know I'm speaking to a lot of clinicians and researchers, and so I want to impart how challenging that is to see your child make progress and then to have no control over those regressions. How challenging it was to hold her during her seizures. She would have cluster seizures that would last anywhere from 10 to 20 minutes, in which she would seize, become alert, and scream, and then go right back into another spasm seizure. And those would last for 10 to 20 minutes. I couldn't give her diazepam every single day because it would knock her out. And then she would sleep for the rest of the day. So traditional rescue meds were not an option in giving her any semblance of a quality of life. The seizures also began to affect her autonomic system. She would stop breathing on her own. Her brain just stopped telling her body to breathe. Her heart rate would plummet. And in any other situation, if we hadn't been aware that it was happening, because I had her at that point connected to a pulse oximeter 24 hours a day, I think she would have died, and they probably would have ruled it as SUDEP because we wouldn't have known what had happened and she had epilepsy. But because we had access to resources, because I had the pulse ox, because we had home nurses and night nurses, and that is a privilege that my family had that most families do not have access to, we were able to keep her alive for just a little bit longer. I will never forget, actually, I had a flashback. We brought Adelaide and my son, her older brother, to Disney World in 2018. I was stubborn and decided that I was not going to let epilepsy ruin our chance at a beautiful family vacation. But epilepsy doesn't care if you're at the happiest place on earth. So we were standing outside the gates to Hollywood Studios, Hollywood Studios here, and she has a seizure for 20 minutes, screaming while I'm holding her and rocking her outside of the gates of the happiest place on earth. Because seizures don't care. Epilepsy doesn't care where you are. And so that desperation led me to cure epilepsy. It led me to research. It led me to the hope that all of you in this room provide to families every single day who are desperate for answers, who are terrified that they are going to walk in the morning and their child won't be alive. We need the hope of research. Adelaide passed away on October 12th, 2019. 6 months prior, through MRIs, we had discovered that whatever was causing her epilepsy, at that point we didn't know, but it was determined that it was neurodegenerative and there was nothing else that could be done. Seizures took our daughter from us. It was not a seizure that killed her, but the degeneration of her brain of 4 years of nearly non-stop seizures took from us the ability to get to know our daughter in the way that any other parent might get to know their child. I no longer got to see when she was happy. We took other cues. But that is something that no parent should have to experience. The medications that we had to test in the hospital, because as you mentioned, those medications, some of them would put her into a coma. And so we couldn't just change medications at home because we ran the risk that we would lose her just from trying a new medication. And these are the risks that parents and caregivers and patients of epilepsy are facing every day, the fear and the anxiety, because isn't she so stinking cute? This is our reality. These are our fears. It is not just SUDEP, although SUDEP is a fear that I lived with every single day. But it was her brain that stopped working, that stopped telling her body to breathe, that stopped telling her heart to beat. That is what took her after 4 years of seizures damaging her brain. As I mentioned, I turned to advocacy during Adelaide's life because there was very little I could do to help her. And so research through Cure Epilepsy, funding, helped me feel like I could do something, I could be productive. After her death, even before her death, I turned to writing. And that became a solace for me. It allowed me to find an outlet to heal. And so I wrote a book. It's called Normal Broken, the grief companion for when it's time to heal, but you're not sure you want to. And I believe that it is probably, unfortunately, incredibly relatable to those of us with a purple lanyard around our necks in this room, because many of us understand and know deep in our hearts that SUDEP ends the life of a patient. Epilepsy can end the life of a patient, but the effects of that death reverberate and are felt by their families and loved ones for the rest of our lives. I hope that this book can be a companion to help those who are still struggling, who are still grieving, because we will always grieve. Grieve and love are two sides of the same coin, and so you don't stop grieving because you will never stop loving. It's hard to heal. It's hard to choose to heal, and so I hope this book is able to meet you wherever you are on your grief journey, whether you have made that step toward healing or not. It is not a guide. I kind of think any kind of grief guide is BS, to be honest, but it's a companion, it's a friend. Allow me to hold your hand and relate to you and help you understand that you are not alone, that yes, we are broken. We are broken by epilepsy. We are broken by those we have lost, but we are normal broken in this room together. Thank you so much for all that you do for our community. Do I stay or do I go?
Thank you, Kelly, so much for that. And again, like I said, this meeting really does sharpen the focus of what we do every day. So I'm going to talk about non-SUDEP seizure-related mortality, and specifically deaths due to accidents, including drownings, pneumonias, aspiration, choking, and status epilepticus. These are my disclosures. So as I mentioned in the introduction, about 1/2 of seizure-related death in people with epilepsy is due to causes other than SUDEP. And while SUDEP is a very important cause of death that remains an intense topic of inquiry, other things can also cut short the lives of people with epilepsy. And some of these are due to seizures themselves. Seizures, in many seizures lead to loss of awareness and bodily control. If they happen in the wrong time and place, they could lead to accidents, falls, motor vehicle accidents, and burns, drownings, and in some cases, those accidents can be fatal. If seizures happen when people are eating, for instance, there is a concern that some of that material can go into the lungs and lead to pneumonia or obstruct the airway and cause asphyxia. Some seizures don't stop on their own, and prolonged seizures or repetitive seizures themselves can lead to metabolic changes, cardiac injury, anoxic injury to the brain and other organs that can lead to death. And since these seizures often require intensive medical care, there's also the possibility of complications of that intensive medical care. So in the next few slides, I'll go over the data on these types of seizure-related death. And I'll also highlight at the end of each section strategies for prevention. So starting with accidental injury. So people with epilepsy have a higher risk for accidents. Many times those accidents can be due to seizures themselves, but the accidents can also be due to the comorbidities of epilepsy, the underlying neurologic disorders that lead to epilepsy, as well as the side effects of epilepsy treatment. If you take population-based studies, overall, the rates of accidental injury is about 20% higher amongst people with epilepsy. And that rate goes up significantly higher with a hazard ratio of about 4 if the person has comorbid neurologic or psychiatric disease with their epilepsy. The majority of these accidents actually occur within the first couple of years of diagnosis, so before people really have a chance to adapt to the life with epilepsy. And compared to the general population, accidental injuries in people with epilepsy are often more severe, often leading to hospitalization more often and have a 2 to 4 times greater risk of being fatal. And as like SUDEP, the frequency of generalized tonic-clonic seizures increase the risk. And common accidents in people with epilepsy include things like lacerations from falls, tongue bites, shoulder dislocations and fractures, which tend not to be fatal, but traumatic head injuries, motor vehicle accidents, and burns and drownings are also common, and those can lead to death. One thing as an epileptologist who treats adults, I spend a lot of time thinking about are motor vehicle accidents because a lot of our counseling and is related to risks associated with driving. The data on rates of motor vehicle accidents amongst people with epilepsy is pretty murky and pretty heterogeneous because it's variable across the world. But about anywhere from 0 to 60% of people with adults with epilepsy have a car accident sometime after their diagnosis. And you look at population-based studies, that risk is about 1.1 to 2.1 higher than the general population. And the greatest risk factor for motor vehicle accidents amongst people with epilepsy is non-adherence to driving restrictions. So people who are driving despite their clinician telling them that they shouldn't. And in one survey in Australia, about 40% of adults with epilepsy admitted to driving despite being told by their physician not to drive. The majority of motor vehicle accidents in people with epilepsy are single vehicle accidents. Usually somebody runs off the road or hits a stationary object. When they happen, thankfully they're often not fatal, and partly that may have to do with the enhanced safety technology in modern motor vehicles. But in low and middle income countries, the rates of fatal motor vehicle accidents are much higher in people with epilepsy. It's not just cars and motorized vehicles. People with epilepsy have higher rates of bicycle accidents as well. Falls are more common in people with epilepsy, and about a quarter to 40% of them are thought to be directly seizure related. We know that people with epilepsy may have disruption in balance and gait and weakness, either as due to the underlying cause of their epilepsy, but also as a side effect of their treatment. And the number of anti-seizure medications increase the risk of falls. Also, because some of our anti-seizure medications can impact bone health, when people with epilepsy fall, their likelihood of sustaining a fracture and complications of that fracture are higher. Burns and scaldings are another common form of injury in people with epilepsy. They may account for about 10% of accidental injuries in people with epilepsy. And the rates of burns related to epilepsy are also higher in low and middle income countries, perhaps related to the fact that more cooking is done on open fires. And the most common locations for burns amongst people with epilepsy include baths, and scalds in baths and hot showers, touching hot surfaces like the stove, the oven, or falling into an open fire. Drowning is another potentially fatal complication of seizures. People with epilepsy have a 15 to 19 times increased risk of drowning compared to the general population. Most drownings, like in this study of medical examiner investigated deaths, occur in the bath, and drownings account for about 8% of deaths in children and young adults with epilepsy overall. And epilepsy is the third leading cause of bathtub deaths in the United States. In rural areas, like for instance in one study in rural China, open water drowning in ponds and rice paddies and things like that was also more common. So how do we prevent the morbidity and mortality due to these accidental injuries, perhaps related to seizures? For a lot of them, well, one is seizure control, as Professor Cross mentioned. Controlling seizures, whether it's with effective therapy, with making sure there's an adequate supply of medication, with utilizing epilepsy surgery when available, can prevent a lot of the morbidity and mortality of epilepsy. And especially focusing on generalized tonic-clonic seizures, both for SUDEP prevention as well as prevention of fatal falls. And then focusing on avoiding avoidable seizures, so making sure that there's good adherence, that triggers like excess alcohol or sleep deprivation are avoided. Assess and monitor for drug toxicity, so making sure that your treatments aren't negatively affecting the balance and walking of patients and making them more prone to falls, making sure that their bone health is good, that if they do fall, they don't sustain a serious injury. And then potential strategies for making sure that the home environment is seizure safe, and following some of these recommendations In this infographic from the Epilepsy Foundation, such as making sure that if you're cooking, there's somebody around you, being cautious when holding hot liquids, taking a shower instead of a bath when you're alone, making sure that the bath door is not locked, making sure that the home environment is safe if in case you do fall from a seizure. But also taking precautions outside the home as well. Obviously, not driving or operating heavy machinery, power tools, etc. if seizures are uncontrolled, and not swimming alone if uncontrolled seizures. Making sure if you bicycle, you wear a helmet, and avoiding open roads in favor of bike paths, for instance, are some ways these types of injuries can be avoided. Another possible complication of seizures in epilepsy is aspiration pneumonia, when oral contents go into the lungs and cause infection, or choking when something obstructs the airway. The good news is these types of complications are relatively rare in otherwise developmentally normal children and adults. And in general, so for instance, one study looked at 600 seizures in an adult epilepsy monitoring unit, where often people are eating in the hospital, and they may happen to have a seizure while that happens. They found no choking events in those 600 seizures, one aspiration event that did not lead to pneumonia. But in children and adults with comorbid developmental delay, neuromuscular weakness, these types of complications are more complicated. Some of them are related to seizures. Some of them may be related to the neurologic disorders that cause weakness and difficulty swallowing between seizures. And then there's status epilepticus, which is defined as a prolonged seizure lasting more than 5 minutes if it's convulsive, or more than 10 minutes if it's non-convulsive, or repetitive seizures without a return to baseline. Status epilepticus carries with it a very high case fatality, about 15% die. But the majority of those deaths are due to what we call acute symptomatic status epilepticus. That is status epilepticus that is related to a direct acute neurologic insult, like an infection or a stroke. And in people with established epilepsy, the risk of death due to status epilepticus is significantly lower, with about a 15% increased risk of mortality in people who have a history of status in established epilepsy, compared to people with epilepsy who don't have a history of status epilepticus. But about 20 to 35% of people with epilepsy have had at least one episode of status. There may be different causes for status, but in some estimates, 20 to 40% of admissions for status epilepticus in people with established epilepsy are due to missed medications. And then there's also people who don't have status but have a history of seizure clusters, that is, repetitive seizures over a short period of time, which is a variable definition in the literature. But they also have an increased risk of mortality. So again, strategies for prevention: seizure control. Controlling seizures will also reduce the risk of status. Avoiding missed medications, maximizing therapy, etc. Rescue medications, so there are available treatments that caregivers can give at home, including intranasal benzodiazepams, rectal benzodiazepams, or oral treatments that can help to stop prolonged seizures or seizure clusters in the home before they become established status epilepticus. Coming up with a plan to address seizures, and especially seizure emergencies prior to them happening, is also something that's been advocated by professional societies and advocacy groups. But as several studies have shown, that these types of interventions, including seizure rescues and seizure action plans, are significantly underutilized, even in people who've had a history of seizure clusters and status epilepticus. So in summary, accidents, pneumonia, status epilepticus account for about half of seizure-related premature mortality. Drug-resistant epilepsy, ongoing tonic-clonic seizures, comorbid neurologic disorders increase the risk of all these complications. And seizure control remains the cornerstone of prevention. Obviously, we want to maximize our therapy, but we also want to anticipate avoidable seizures due to missed medications or other seizure triggers. Make sure that we're implementing seizure safety precautions inside and outside the home, especially if somebody has poorly controlled seizures. And make sure that we're talking about seizure action plans and prescribing rescue therapies when it's appropriate. So with that, I just want to thank you for your attention. We'll reconvene all the panelists, all the speakers at the end for the Q&A. So with that, I'd like to introduce the next speaker. So the next speaker is Dr. Leah Blank, who's assistant professor at the Icahn School of Medicine at Mount Sinai in departments of neurology and population health science and policy. And she's an adult epileptologist and health services researcher who's particularly interested in how to design health systems that improve outcomes, reduce premature mortality, and reduce care disparities by delivering high-quality epilepsy care. Thank you, Leah.
Hi, so first I'd like to thank you for inviting me to speak about what I think is a very important topic, which is comorbid diseases in adults as important predictors of premature mortality in epilepsy. Okay. All right, so these are my disclosures. I have recent funding from the National Institutes of Health that's unrelated to the material I'm presenting. So this is a big topic, and again, I think an important one. So I'm going to try to give an overview of comorbidity and comorbid disorders in epilepsy first, and then focus a little bit on neurologic comorbidity and psychiatric comorbidity and their relationship to premature mortality. And then finally, I'd like to touch briefly on social determinants of health, medical comorbidity, and its impact on premature mortality. So to start, just to make sure we're all on the same page, what is comorbidity, right? So this is from Oxford Languages, which I think used to be the Oxford Dictionary of English, the English language. So they define it as the simultaneous presence of two or more diseases or medical conditions in a patient. So when we're thinking about people with epilepsy, they already have epilepsy, so that's one, and then really any other disorder occurring in the same person. So that could be, especially in adults, lots and lots of different disorders. So how should we think about grouping those, and how should we think about the relationship to epilepsy and mortality? So as a neurologist, I think like Dr. Friedman, I like to think of them in these sort of three buckets. So the first is neurologic comorbidity, right? So especially in adults, this is possibly and perhaps even likely the etiology of the epilepsy. So things like stroke and dementia, but could also be things that are maybe not related to the epilepsy, like migraines. And then I like to think about psychiatric comorbidity. And again, as many people have brought up, psychiatric disorders and neurologic disorders are all coming from the same organ, right? These are all brain disorders, and so we think these are intimately related to epilepsies. And then finally, last but definitely not least, I think about medical comorbidities. And these may be related to the epilepsies, but I think in many adults, they are often unrelated. I'm going to focus a little bit more on the neurologic and psychiatric comorbidity, again, because these are brain disorders, but also perhaps because they're brain disorders, there's a lot more data on premature mortality related to neurologic and psychiatric comorbidity in adults with epilepsy. So this is a slide to remind us all of the epidemiology of epilepsy, which I think helps us sort of keep in mind who we're talking about and what kinds of deaths we're thinking about. So on the y-axis, you can see the incidence of epilepsy, or the new cases of epilepsy per 100,000 person years. And then on the x-axis, you can see age in years. And I think you can all appreciate that there's a lot of new epilepsy diagnosed in the first few years of life. And then as we get older, there's fewer new cases of epilepsy diagnosed. And then as you reach middle age, it really picks up again. So when you're thinking about adults, and Dr. Donner will later talk about the first part of this graph, which is children. But when you're thinking about mortality in adults, you're really thinking a lot about older adults, because the people who die with epilepsy in the adult population tend to be older. So the disorders that are leading to their death are often disorders that you think about in older adults. Okay, and then here's the real question. Why are we even talking about comorbid disease? Why is it important? Why is it part of a meeting about mortality and epilepsy? And this is why. And this is why I think it's so very important, because comorbid disease in adults is the most common cause of death, right? So if we're thinking about how can we reduce premature mortality in adults with epilepsy, we really can't leave comorbid disease off the table, because then we're missing an opportunity to prevent many, many, many deaths in our patients. So this is a study from community dwelling adults with epilepsy. So these are people with epilepsy that are just living their lives. And if you look at the causes of deaths in this cohort, you can see that the top 3 causes of death account for almost 60% of the deaths. And none of them are epilepsy or seizure related, right? So we have non-brain cancer, cardiovascular disease, and then finally cerebrovascular disease, which, like strokes may be related to epilepsy. And similarly, so that was, outpatients, people living outside of the hospital. This is a study of people in the hospital, so risks for in-hospital death in people with epilepsy. And you can see again that the biggest predictor, so if you look at the odds ratios, age at 18 is a very, very, very strong predictor of dying in the hospital, which is, again, not surprising. If you're an older adult, you're more likely to die in the hospital than if you're a younger adult. But then if you look again at some other strong predictors in this study, we start to see other comorbid disorders. So we see things like neurologic comorbidities, like traumatic brain injury and central nervous system infections. And then we see some medical comorbidities. So having kidney disease put you at higher risk of dying in the hospital. All right, so let's focus in a little bit on this idea of neurologic comorbidity and its contribution to premature mortality in epilepsy. So as we all know, neurologic comorbidities are very commonly associated with epilepsy in adults. Most adults with new epilepsy have focal epilepsy, and these are often associated, again, with common disorders of older adults, including things like stroke, brain tumors, TBI. So in turn, these neurologic comorbidities are associated with premature mortality. So you can see in this table on the side data from many, many, many studies looking at some common neurologic comorbidities in adults with epilepsy. And then in the other column, you can see the standardized mortality ratio or adjusted hazard ratio. And so both of these are ratios comparing people with epilepsy to people who don't have epilepsy. So if the number is 1, it's the same. There's no excess mortality or excess hazard. But if the number is more than 1, then you're seeing excess mortality in the epilepsy population or excess hazard of death in the epilepsy population. And you can see that really all of these numbers are above 1, which is not surprising because neurologic disorders and epilepsy are going to be so intimately related because they're occurring in the same organ. And again, not surprisingly, some of the highest excess mortality is seen around things like stroke and dementia and tumors. So what about psychiatric disease? As Dr. Friedman alluded to earlier, we know that psychiatric disease and epilepsy are very intimately related. So we think that these are both network disorders of the brain, and there's a strong bidirectional relationship between common psychiatric disorders and epilepsy. So we know that if you have depression, you're at higher risk of developing epilepsy, and vice versa. If you have epilepsy, you're at higher risk of developing depression. And unfortunately, these psychiatric comorbidities are also associated with increased premature mortality. So this is a study that looked at a large group of people over time, and you can see that the people that had neither epilepsy nor a psychiatric disorder had 11 or just under 12 deaths per 100,000 person years. And so that was the reference population. And then if you look just below that, if you have only epilepsy, your hazard of dying is increased to almost 3. And if you have only a psychiatric disorder, your hazard of dying is also increased to something like 2.5. But if you have both together, then your hazard is even higher, right? Almost 5. So why is that? And it may be that psychiatric comorbidities are associated with other medical comorbidities that might increase your risk of dying, right? So one group looked at this and found that if you had a psychiatric disorder and you just took into account sex and age, that you had an increased risk or increased hazard of dying. But once they added things to the model that accounted for other medical comorbidities, hospitalizations, days in the hospital, that association went away. And the only predictor of mortality became things like self-harm or substance use disorders. Also discussed by my colleagues is we know that psychiatric comorbidity is associated with an increased risk of suicide, and that people with epilepsy already have an elevated lifetime prevalence of suicide and attempted suicide. And there's been many studies and many meta-analyses that show over and over again that people with epilepsy have suicide rates that are higher than would be expected for the general population. And this gets even higher when you add in a diagnosed psychiatric illness. So some studies report like up to 9-fold increased risk. And then if you know that that psychiatric diagnosis is more severe, so if patients that are treated with antipsychotic drugs have then even higher increased risk, so it's something like a 10-fold increased risk of suicide. Okay, so now I'd like to touch just very briefly on social determinants of health, medical comorbidity, and premature mortality. So these remain major risk factors for premature mortality in adults with epilepsy and are somewhat understudied. So this, to bring us back to the beginning of the talk, is a totally different study with a different cohort that had the same results, right? So these are adults, and the two most, with epilepsy, and the two most common causes of death are cardiovascular disease at almost 20%, and you can see that there's some excess risk seen in the epilepsy population with a standardized mortality ratio higher than 1. And then the next most common cause of death was non-brain cancer with a proportion of about 12% of deaths, and doesn't look like there's excess risk there. This is just to remind us that medical comorbidity is the main cause of death for adults with epilepsy. And then, again, a little bit understudied, but we know that social determinants of health are also a major risk factor. So this was a case control study where the authors looked at people who had died with an epilepsy diagnosis and compared them to people who were still living with epilepsy. And they found that people who had died were more likely to have been rural residents. They were more likely to have been racial minorities, in particular Black Americans, and they were more likely to have had multiple comorbid conditions. So what can we do, right? We really need to be identifying and treating comorbidities in adults with epilepsy. And this is a slide that Professor Cross showed earlier and that I'll just remind you of. So the y-axis shows the cumulative hazard of mortality. So this was a study of adults with newly diagnosed epilepsy. So at the beginning, you're just at 0 is the date of their diagnosis, and then you're looking at their chances of dying over time, and the x-axis is the years since diagnosis. And the people are split into 3 groups. So the top bar, who were most likely to die, never saw a neurologist. The middle group saw a neurologist but didn't get referred to a comprehensive epilepsy center, and the least likely to die were those who were exposed to a comprehensive epilepsy program. And when I first saw this study in 2019, I was relieved first, because I was like, phew, I am a epilepsy doctor, and it turns out that what we're doing hopefully is actually working. And then I think I and many other people might think, oh, well, what are we doing? We're treating their seizures, we're like getting them on better, more, faster medications, we're referring them to surgery because we already saw how important surgical treatment can be. But I think from the data that I just showed, it's very possible that that's not at all how we're improving mortality, and that we might be improving mortality by better treatment of comorbidity. So maybe, we have neurologic training and maybe some psychiatry training, and so maybe we're treating their neurologic and psychiatric comorbidities and identifying them better. And maybe, especially for the comprehensive epilepsy care programs, these are usually at big centers, right? So maybe we see the patients and we say, looks like you need some help with your heart, or looks like your diabetes is really out of control, and we're referring to other specialists in our center. And that might be one of the main ways in which we're impacting mortality. All right, so these are the things that I'd like you all to remember. So comorbidity is a primary cause and predictor of premature death in adults with epilepsy. It is really important that we ensure that comorbidities are diagnosed and treated, because thoughtful treatment of neurologic, psychiatric, and medical comorbidity may help reduce premature mortality in adults with epilepsy. Thank you all.
Great, thank you, Lynn. Next up is Dr. Elizabeth Donner, who needs no introduction here, but she is, among other things, she is the co-chair of PAME. She is the associate professor at the University of Toronto and director of the Epilepsy Center and at Toronto Sick Children's Hospital, and has been a lifelong passionate advocate for people with epilepsy, and especially around mortality in epilepsy.
Thank you, Dan. Thank you. I apologize. I'm losing my voice at the beginning of the meeting, which is perhaps a bit of a bad sign, but we'll see how it goes. The other thing to note is that when I go kind of towards the end of this session, I realize there's a lot of overlap. But I'm going to focus on children, because I am a child neurologist, and talk to you really about something I'm excited to talk about, which is prevention, right? So actually, as part of our PAME planning this year, we were really excited to focus on prevention. We have prevention now, and we have prevention again towards the end of the day. And later we're going to be talking about creative strategies and innovations for prevention of SUDEP. But right now I want to talk to you about how to prevent non-SUDEP related mortality in children. And a lot of this has already been talked about, but I do want to address that while we know that people with epilepsy have an increased risk of premature mortality that's maybe 2 to 3 times the general population, it is quite a bit higher in children. And the reason for that really really reflects what Dan mentioned earlier, which is, first of all, thankfully, it's rare for children to die. So any increased risk obviously is noted, thankfully. But it also reflects the relatively high mortality among children with significant neurological impairment. And that's kind of what we're talking about when we talk about this comorbidity or coexisting disorders. And so we'll talk about that a little bit. So most of the deaths related to in children with epilepsy, most of them, about 90% of the time, are in children with comorbid disorders. It's thankfully quite rare for children with epilepsy to die if they don't have any associated problems. There's a nice study by Dr. Abdelmanin. This is out of the UK using the British Pediatric Society surveillance program, and they found the annual incidence of deaths among children with epilepsy to be 0.65 per 100,000. So thankfully a relatively low number, but it's so tragic when we see it, especially when we think it can be preventable. And we've talked about already up here today, but just this idea that deaths could be unrelated to the epilepsy. Obviously, children can die from other causes, but this idea that deaths can be somehow linked to epilepsy, and that's what I want to talk a bit more about. So most deaths in children are not epilepsy related, and this has been demonstrated multiple times. I highlight 4 studies there. Ann Berg's work from the US, 2 studies from the UK, Dr. Ackers and Dr. Abdelmanin, and then Dr. Harvey's work from Australia. And what we see there is that definitely at least 60%, but more commonly 70 or up to 80% of deaths in children with epilepsy are not related to seizures or the epilepsy per se. And the most common cause of death in children with epilepsy is actually pneumonia. And we're going to talk more about that. I know Dan talked a little about aspiration, but this is such a big issue in children. And so let's think about this. So children with epilepsy, this really has to do with the co-occurring existence of epilepsy and cerebral palsy, which is what CP stands for there, or other kind of neurodisability conditions in which children are impaired in their ability to move around and sometimes to communicate. And what that does is it affects swallowing and it affects breathing and digestion, and these things can result in death 2 ways. First of all, as Dan mentioned, people can aspirate, which is another word for choking. And so you can actually aspirate or choke during a seizure. This is going to be a lot more common in children with cerebral palsy because they're not as good at coughing and moving things out of their airway. But the other thing that can happen that I think we're not monitoring more often enough is that every time really anybody has a seizure, but especially children who don't have that same body strength, every time they have a seizure, they can have what we call little micro aspirations. So this is little tiny bits of choking, but what it causes over time is a chronic lung disease that then predisposes them to early mortality. So that aspiration can occur with or between seizures. So, yeah. So how do we prevent this? Well, the first thing really is to be aware of it. And what I find in my practice is we really, really need to work closely with families to get assessments of children's swallowing and consideration of moving to G-tube feeds or feeding through a tube that's in the stomach so that we bypass the airway and minimize both choking with a seizure, without a seizure, and those little micro chokings that cause chronic lung disease. And there's really nice evidence, actually, that paper by Blair in 2019, that actually care improvements have reduced deaths in children with cerebral palsy, for example. So when they looked at death rates in children with cerebral palsy, with or without epilepsy, and they looked at the rates over like 5 decades or something, the improvements in care that we've seen in the 90s and the noughts reduced mortality in children with cerebral palsy compared to the rates of death that we saw like in the 1970s and 1980s. So, and I think most of us who treat children in this room would agree that we've seen increased survival in this population as we've improved care. So when we think, so there's not a lot of comorbid diseases in children. I know that was my topic, Dan, but there's not a lot of comorbid diseases in children that actually contribute to death. But but I do think it's worth dissecting a little bit some of the seizure and epilepsy-related causes of death in children, because I think, I like the word prevention, and I think this is where we can actually act and prevent. Okay, so this is again a series of studies, and the bars show you the causes of seizure or epilepsy-related deaths in these studies. You can see SUDEP is the blue bars, and when I talk about SUDEP in children, I use this slide to tell people how important SUDEP is. But today, I'm using this slide to show you that the other causes are status epilepticus, aspiration, which we just talked about, ASM, which stands for anti-seizure meds, so related to anti-seizure meds, and Dr. Josephson is going to give us a whole talk on that next, and drowning. So let's talk for a minute about status epilepticus and why this is important. So status epilepticus can be more common in certain comorbid genetic diseases, such as Dravet syndrome. And we know that deaths in Dravet syndrome, children with Dravet are more likely to die than children with perhaps some other forms of epilepsy. But the mortality due to status epilepticus in children is really directly linked to how long the seizures last. And for those of you that are families in the room, just to define status epilepticus, it really just means continuous seizures, depending which definition we're using. Sometimes it means 15 minutes, sometimes it means 30 minutes, but the longer that people have a seizure for, the more likely they are to die. Dying from status epilepticus is relatively rare in children, and I think that the reason for that is because we tend to be very aggressive with treating seizures at home before children even come to hospital. And there's very good evidence that earlier treatment reduces mortality. We know that there are certain high-risk conditions, for example, like Dravet syndrome, that we need to identify these children to know that they're at risk of status epilepticus. We also know that mortality is affected by the emergency medical services or the paramedic protocols within regions. So we know that there's vast disparities even within the Greater Toronto area. I know that if one of my families lives in one end of the city, they'll get a different type of paramedic with a different type of skills coming to their house when their child is in status epilepticus than if they live in another part of the city. Brandy's nodding voraciously. It's extraordinarily frustrating. And we try and partner with these practitioners to really say, can we have a protocol for this child in their home when your ambulance goes to see them? We also know that once kids get to the hospital, there is care is sometimes hampered by knowledge gaps in the emergency medicine providers at local hospitals. There are gaps in the dosing and using the proper dose of medications, and there's a lot of fear around the side effects of medications and whether they can affect breathing. So the care pathways are very variable. So I think it's pretty obvious that this is an area ripe for prevention. If we can enhance our seizure monitoring of children in the home so that when we know that a child is one who's at risk for status epilepticus, that parents know as soon as that seizure starts, because if a child is seizing already for 20 minutes before someone in the home is aware, then that is lost time. And I have to say, I often feel very lucky that I'm a pediatric neurologist, Dan, because I know that I work with families and my patients all get to live with adults who care for them and help to keep them safe at home. The other thing is patient-specific treatment protocols, and really we need practitioner education to reduce that time to treatment, and that will reduce deaths. I want to talk about drowning for a moment. We know that epilepsy is specifically a risk factor for childhood drowning. And so up to 5 times, children with epilepsy are up to 5 times or 6 times more likely to drown than children without epilepsy. I suppose that's not surprising, but I find it quite disturbing, and we'll talk a little bit about it. So this was a nice study by Dr. Franklin and his group, which actually, instead of looking at people with epilepsy and whether they drowned, they looked at all drownings in their jurisdiction, and they identified what were the comorbid diseases when children die. And what they found was that children who died from drowning, 4% of them had epilepsy. in contrast to within their population, about 1% of people have epilepsy, right? So drowning in epilepsy is a real problem. There was no other medical, in this study, there was no other medical condition that increased risk of drowning in children other than epilepsy. We actually looked at drowning in Ontario. This is a paper published that we published back in 2018. And I want to look at this data. This was not just in children and adults too, but just as we think about prevention. Because let's first think about where people drown. About half of the people in our cohort drowned in the bathtub. This is so distressing to me. I just find this so distressing because we talk to families all the time about water safety, but somehow that's not translating. And so we're not doing it right. I mean, if there's one thing I've learned like through the SUDEP advocacy and PAME and all this, is that sometimes you need to rethink your message. And if the message isn't working, we're not doing it right. So we have to think of some better way to talk to people about water safety. Half of these in bathtubs and half of them in deep natural water sources. And actually, that has caused me to rethink how I talk to families about water safety, because even with children with infrequent seizures, families often want their children to be able to swim and enjoy water. But I really, having lost a patient to a deep water drowning and then doing this research, I really talk to families now a lot about considering using a life jacket if the depth of the water is beyond what you could pull a child out from. Because in a pool, it's one thing, you can yank a child out if you see them having a seizure, but people that I know that have drowned seizing, even with someone there, they can't get them out, right? Because the water is deep. The other thing is that you might assume that the drowning in people with epilepsy is in people with epilepsy that actually has a comorbidity. But actually, I know I'm supposed to be talking about comorbidities, the drowning tends to happen in people who don't have a comorbidity. So the majority of people did not have a developmental delay, suggesting that, but there was psychiatric comorbidities, but it's only 12% of the people that drowned actually had like a motor disability. So it's not necessarily that they're not able to kind of keep themselves up and afloat. And then I want to talk about suicide in children. So we already heard about the increased risks of suicide in people with epilepsy, and we know about the coexistence of anxiety and depression. But 25%, 1 in 4 children with epilepsy have depression and anxiety. And I honestly feel that we are forgetting about this in our pediatric clinics. I don't work in adult medicine, but it's my impression that perhaps in adult medicine they're doing a better job of screening for this. There's a nice study there, a couple studies quoted on the bottom, but young adults and children with epilepsy are more likely to have suicidal ideation and self-injury, and when they do commit suicide, they're more likely to try again. So when we think about prevention, we really need systematic assessment and early detection of suicide, of depression and suicidal ideation. And in fact, it was shown that when you do screen for suicidality and depression in a pediatric neurology clinic, actually health-related quality of life improves and depression reduces. So this is proof that it would work. So I'm going to leave it there. I think that when we think about strategies for preventing non-SUDEP mortality in children with epilepsy, it's really about individual and system level strategies. So we need risk assessment for children for their aspiration and their chronic lung disease. We need to screen children for mental health disorders. But we also need broader initiatives around water safety, around protocols for emergency care. And I think if we pair those things together, we'll be able to see an improvement. Thank you.
Thank you, Elizabeth. And finally in the session, I'd like to introduce Dr. Colin Josephson, who's Associate Professor of Neurology and a member of the Department of Clinical Sciences and Health Center Informatics, O'Brien Institute for Public Health, and the Hotchkiss Brain Institute at the University of Calgary. He is an impressive clinician scientist, medical informaticist, who's going to talk to us about the role of anti-seizure medications.
Great, thanks. It reminds me Elizabeth's comment about RuPaul's Drag Race, where they say never go last because most of your material's taken by that point. So I apologize for repetition. So immediately there's repetition. So of course Dan showed this slide as well. So the unfortunate truth is that yes, epilepsy death is premature mortality is increased in epilepsy. This is primarily emphasized exaggerated in young children or in young adults, where the standardized mortality rate is exceptionally higher. But even as we age, the standardized mortality rate continues to be about 2 to 3-fold higher in people with epilepsy as compared to the general population. As well as Leah said, as well as you can see on the right there, although seizures themselves are a major cause of death, both neurological, non-neurological accidents and suicide are all significantly higher in people with epilepsy as well compared to the general population. So these are very important causes of death that we need to pay attention to. So in order to try to reverse or to try to intervene, it is important to conceptualize why patients with epilepsy do have an increased risk of death. Now, this can be due to the underlying reasons why they have epilepsy. It can be due to the epilepsy itself, due to seizures, and what will be the focus of the talk today, potentially due to epilepsy therapy itself, which can directly relate to premature mortality. So, of course, most of the emphasis and most of what we emphasize in terms of people with epilepsy is the risk from seizures. So, of course, in particular, SUDEP. The idea, of course, many of the central hypotheses now are that a patient has a seizure. This, of course, involves the brainstem. This can result in apnea, and then, of course, can then result in terminal apnea if this is not reversed. But what's important to remember is that, as you can see, in terms of the definition of SUDEP, this involves with or without evidence of a seizure. So this becomes a little bit difficult because this, as you can see, is very similar to the definition that we'll see in sudden cardiac death, which also involves sudden and unexpected death, often within 24 hours if observed alive and symptom-free before then. So there is some semantic confusion, and this becomes quite important. The idea here being that you could have very divergent views over why patients are dying suddenly in our population. So if you look at overall sudden death registries, as I mentioned, you could come to very different conclusions. So on the left there, what you can see is that you may take the conclusion that patients that are in that population that have sudden death are being misdiagnosed as sudden cardiac death, but in fact have SUDEP. Conversely, though, as you can see on the right, you can come to the alternative conclusion. And this was an interesting study done in Portland over about a 10-year period where they identified all witnessed sudden cardiac death. What they found was about 4% of these patients had epilepsy. So if you extract that or extrapolate that to the general US population, that means that about 16,000 people with epilepsy are dying of sudden cardiac death per year. And the argument then would be that this is about 4 times the rate of SUDEP. And this is not a semantic issue. This is not trivial. This is really important to understand and to clarify this definition, because either sudden cardiac death is SUDEP in people with epilepsy, and if we're hyper-focusing on seizures, we're missing potentially remediable causes, or it's a very separate entity, and if so, we're unfortunately missing it. It's being essentially missed and ignored by many researchers and clinicians. And again, that's important because we can potentially intervene in these cases. Now, of course, seizures are bad for the brain, but they're also bad for the body, and this is potentially some of the reasons behind this. We do know that repeated seizures can cause repeated hypoxemia and myocardial ischemia, and there's cardiotoxic effects from repeated seizures that can result in excess catecholamine release. This can result in myocardial stunning. This can result in interstitial fibrosis and can lead to increased risks of ischemic heart disease, heart failure, and arrhythmias in patients with epilepsy. So on the top right, I don't know if I have, oh, there we go. So what you can see, this is a measure of what we call T-wave alternans. That could be a marker for malignant arrhythmias. In people with epilepsy, whose seizures are well controlled, that risk of T-wave alternans is about the same as the general population. But you can see here in people with drug-resistant epilepsy, their rates of T-wave alternans is actually about equivalent to somebody that's had ventricular tachycardia. So they're extremely high risk of malignant arrhythmias. Likewise, seizures themselves probably lead to autonomic dysfunction. They can lead to vasovagal reflexes, which can then lead to asystole. So if you already have a weak and fragile heart, that can make things worse. So there are ways that we can intervene beyond just seizures alone. Now, having said that, treating seizures is clearly an ideal way to start to approach this issue. Professor Cross talked about this a little bit as well, but of course, as we can see here, adherence to medications is important. So in those that were non-adherent to medications, their hazard of premature death was about threefold higher. Now, there has been some controversial evidence about the risks from our medications on premature death, but in a crude analysis, as you can see here, there may be some associations with an increased risk of death, but the issue is this is often confounded by indication. So this is an epidemiological term, but the idea is you have lots of bilateral tonic-clonic seizures that directly increases your risk for premature mortality, but it's also associated with greater uses, higher doses, and more anti-seizure medications. So this entire relationship, becomes confounded. And so in actual fact, our anti-seizure medications are good because they can prevent seizures, which can then prevent some of the issues that I just talked about in terms of not only brain health, but overall body health as well. Now, having said that though, no decision that you make is without risk. So as you can see from the diagram which I conceptualized here, obviously epilepsy therapy can result in comorbid somatic disease. So that's diseases involving the body itself. In terms of psychiatric disease, and therapy itself can directly lead to premature mortality as well. So it is important to understand this as well. So although we want to treat seizures to prevent them and the deleterious effects they have on the body, this decision to treat them can also have risk itself. So what are some of these risks? Well, there is theoretical risk for arrhythmias, so cardiac arrhythmias as we talked about. There are mutations in the SCN5A gene. This is associated with slow inactivation of a cardiac voltage-gated sodium channel. If you have an SCN5A mutation, you're at increased risk of things like ventricular tachycardia, which is a very bad arrhythmia that can lead to premature mortality in the general population. Similarly to a syndrome called Brugada syndrome, which can also lead to premature death, as well as sudden death itself. Now, interestingly, some of our sodium channel blocking agents, such as lamotrigine, carbamazepine, and lacosamide, actually interact with this cardiac channel as well. So there is theoretical risk that some of our medications could potentially predispose to arrhythmias within this population. Likewise, we know that some of our enzyme-inducing anti-seizure medications can also cause metabolic dysfunction. So this is a really interesting study done by Scott Mintzer about 10 or 12 years ago. What they did was they looked at patients that were on carbamazepine or phenytoin, which are both enzyme-inducing anti-seizure medications. They drew cholesterol levels, and including LDL levels. And then what they did was they transitioned them to a non-enzyme-inducing anti-seizure medication like levetiracetam or lamotrigine. What they found was almost, when you compared to the pre to the post-draw, there was significant reductions in cholesterol and LDL levels in patients that were transitioned from enzyme-inducing to non-enzyme-inducing anti-seizure medications. When you did a pre-post-draw, in the general population, what you can see here is that there really was no difference. Some people had a drop, some people had an increase, but there was a consistent decrease when we transitioned from an enzyme-inducing to a non-enzyme-inducing anti-seizure medication. And of course, dyslipidemia is a major risk factor for cardiac disease. Likewise, some of our medications have also aberrantly affect metabolic pathways. So in particular, valproic acid, anywhere from about 15 to 75% of patients can gain weight on this. Valproic acid can interact with the hypothalamus to increase appetite and energy intake. It can affect adipose tissue. It can result in leptin resistance. It can affect mitochondrial function. It can affect LUT1 activity. All of this can lead to hyperinsulinemia, insulin resistance, decreased peripheral glucose uptake, leading to obesity. And what's even more interesting is this was a study that was done in children in which valproic acid was started here at this point. We could look at mean serum insulin levels and insulin to glucose ratios. what you'll see is that these increase after starting valproic acid. The arrow is when lifestyle interventions were actually instituted at that time. And as you can see, although it was partially reversed, it didn't go back to baseline when the patients were off of valproic acid. So again, some of our medications can have effects on body weight, body mass index, and this of course can affect heart health and premature mortality. Back to enzyme-inducing anti-seizure medications, this was some work that we did using population-based data in the UK. What we looked at was the effects of long-term use of enzyme-inducing anti-seizure medications on cardiovascular disease, including ischemic heart disease, TIAs, and strokes. And what we found was that over about 25 years, use of enzyme-inducing anti-seizure medications increased your risk for cardiovascular disease by about 20%. Now, the absolute risk is still relatively low. By about 25 years out, the absolute risk difference was about 5%, so I don't want to alarm people too much from that perspective, but there is a slightly increased risk. What's also important to note is that this is dose responsive. So if you take the WHO recommended daily dose of your enzyme-inducing anti-seizure medication, your risk of heart disease was increased by about 50%. If you require double the WHO defined daily dose, your risk was actually about 2.38-fold higher than if you were not taking an enzyme-inducing anti-seizure medication. So again, we know that there are long-term risks of cardiovascular disease, especially with enzyme-inducing anti-seizure medications. Now, having said that, as we talked about earlier, psychiatric disease is also extremely important in epilepsy. Unfortunately, people with epilepsy, up to 30 to 40% will have comorbid psychiatric disease. Now, the issue with that is that a number of our medications can also result in psychiatric disease and have psychiatric adverse effects. So this is a heat map here looking at the rates of psychiatric adverse effects from our medications. Highlighted here are things like aggression, nervousness, and depression. And in particular, medications that act on what's called the SV2A receptor and medications that act on what's called the AMPA receptor are associated with increased risk of aggression, nervousness, depression, and anxiety. And as Leah had pointed out earlier, this is extremely important because although epilepsy itself increased risk for things, premature death related to external causes, related to suicide, and related to accidents, if you combine epilepsy with psychiatric disease, that risk either doubles or at other times is actually in fact tenfold higher than if you did not have psychiatric disease. So through our medications, if we are causing issues with psychiatric disease, that can also increase the risk of premature mortality in this population. Likewise, anti-seizure medications can also affect bone health over the long run. And this is again important because as you can see here on the left, if you look at the rates of premature mortality in people with fractures compared to the general population, as you can see, when you get older, your risk of premature mortality related to a fracture incrementally increases. And this is problematic because this is a study, again, that we performed using population-based UK data, that showed that incident epilepsy is independently associated with increased risk of osteoporosis, but likewise, both enzyme-inducing and non-enzyme-inducing anti-seizure medications are also associated with accelerated rates of osteoporosis in our patient population. So you can see that there, in terms of incident epilepsy, that increases significantly over time. What's interesting, if you look at people who only have epilepsy and you compare enzyme-inducing versus non-enzyme-inducing medications, there really was no difference. So in other words, all of our anti-seizure medications do appear to have an impact on bone health over the long run, which can have detrimental effects on premature mortality in this patient population as well. So again, I know we've seen this graph many times. It's a bit self-serving. So this was a study that we performed in Alberta. In fact, probably of any study I produced over the last 8 years, this is the one that I'm most proud of. And as people had mentioned, what we did was we looked at all patients within Alberta. We looked at everybody that was diagnosed with epilepsy. Here, care is a time-varying covariate, so you start on the green line. Say, for instance, at 1 year, if you were transitioned or transferred to a neurologist, you move to the yellow line. If at 3 years you went to a comprehensive epilepsy care clinic, you move to the blue line. And what we found was that with neurologist exposure, you can decrease mortality by about 15%. By a comprehensive epilepsy program, you can actually decrease mortality by about 50%. And I think, as Leah had mentioned earlier, I don't think that this is mostly due to seizures. In fact, working in that comprehensive epilepsy clinic, most of the patients we see are drug-resistant patients. So having talked about the medications to date, I think one of the things that we are able to do as epileptologists is we can anticipate and proactively deal with the consequences of our medications as well as comorbid diseases. So when we use medications like enzyme-inducing anti-seizure medications, when we use medications like valproic acid, or when we use medications that may adversely affect psychiatric health, we can anticipate that, we can proactively deal with that, and therefore we can avoid mortality that may be related to some of our medications. So having said that, do anti-seizure medications, are they the cause or the prevention of premature mortality in epilepsy? Well, if I'm honest, probably both. Epilepsy obviously confers an increased risk of death that is mediated in part by seizures. But some anti-seizure medications also have unintended consequences on comorbid disease. But I think the take-home point that we really need to emphasize, and I hope that I made today, is that we cannot mitigate the risks of seizures and the substantial impact it has on premature mortality without treating them. If they go on, I've shown you that not only are they bad for the brain, but they're bad for the body as well. And therefore, if we do not intervene, they will lead to premature mortality. Having said that, we can mitigate the impact of anti-seizure medications on health. In order to do this, what I would say is that we need to advocate for future research that looks at, for instance, avoiding enzyme-inducing anti-seizure medications or broadly acting sodium channel blockers potentially improve outcomes, especially in those with cardiac disease. While emphasizing novel brain-specific mechanisms potentially improve outcomes so they don't cross-react with a number of targets within the body itself. And I think most importantly, and this is what I hope that we are doing in comprehensive epilepsy centers, is does regular monitoring for cardiac disease, metabolic risk factors, and psychiatric disease lower the risk of premature mortality in people with epilepsy? Because again, I think this is going to be something that's exceptionally important moving forward. I hope that I emphasized that earlier with the sudden cardiac death as well, that even beyond treating seizures alone, if we understand the root causes, such as the effect it has on the heart, the effect it has on psychiatric disease, the effect it has on bone, we can mitigate and make a huge impact on premature mortality in this population. So with that, I'd like to thank you. And in particular, I'd like to thank Kelly for her speech as well. As a data scientist, sometimes it's easy to become a little bit dissociated from the clinical scenarios. And I think that really hammered home why we're doing this research and why we're so proud of what we do. So thank you very much.
Thank you so much, Colin. And I'd just like to invite the panelists actually to come up. And we have about 10 minutes, is that correct, for Q&A? 10. I'll give a moment for everybody to come up. Kelly, if you're and if you could wait for the microphone to ask your questions, so the whole room can hear you and we can hear you up front. All right. Okay, right over there.
So much, ma'am. So I was really surprised by the amount of seizure-induced mortality occurring in the bath. I didn't realize that it was such a large preponderance of the overall drownings. And so my question is, have you heard of neurologists prescribing or recommending wearing a life vest or something of that kind in the bath? Would that be helpful?
Good.
I think, do I have to do some? Oh, great. Thank you very much. So the deaths that occurred in drowning, at least in our series, people were clearly alone. They were mainly like people who lived alone. So I don't know that a life vest would save you, because I think, like, I wouldn't probably keep your head adequately above the water. I think that what we need people to do is not take baths if they have epilepsy. And take showers basically. And also people need to be aware of that fact that if your shower has a lip and you've like a ledge or whatever, that water can collect within the shower as well. So you need to make the environment safer, I think.
Thanks so much.
I have a question. I think that, can you hear me well?
Mm-hmm.
Okay, I think this is directed to Dr. Donner. On a lighter note, when I started my flight from Hamilton, you were a professor in University of Toronto, and I think even now you are a professor because I heard somebody mentioning associate professor. Is there a correction there?
Thank you, yeah.
Okay, very good. So
Rajesh is fixing my bio. Thanks, Rajesh. Okay.
So
anything else?
So now the scientific content is a 5-year-old child with a diagnosis of epilepsy, with the convulsion, MRI normal, genetics normal, multiple anti-seizure medication, one day found dead in the bed, anatomical and toxicological autopsy did not reveal a cause.
Yeah.
So that fits in with the diagnosis of definite SUDEP. But what if that patient had a cardiac arrhythmia that was never detected? So are we actually overestimating SUDEP, or how do we deal with such a situation?
Well, I think any of us could address that, but really what you're getting at, Rajesh, and thank you for the provocative question, what you're getting at is this idea of what do we consider to be a SUDEP death and how do we define SUDEP, right? And I think we'll talk about SUDEP more later in the day, but SUDEP is an unexpected death. That doesn't mean that ideally in the end it's not somehow explained by something, so I still consider that to be a SUDEP death. I don't know. Dan, you do lots of SUDEP adjudication. You want to comment on that?
I mean, I think the issue is what we were working with is a phenomenological definition and not a etiological definition. As Colin showed in his data, right? There is a significant overlap with sudden cardiac death, circumstances, risk factors, and with epilepsy sudden death. And just because you have epilepsy doesn't mean you also aren't at risk for sudden cardiac death as well. So maybe even a heightened risk compared to the general population. So right now we have a phenomenon, and that's hopefully what we are all working towards in this room, is come up with clear mechanisms and pathophysiology that we could refine our definitions.
Better answer than mine. Good.
Go ahead.
Oh, hello. First off, thanks so much for all your hard work, and it's just a pleasure to be here. Just following up on the EMS comment, that was something that was talked about yesterday, that we need better protocols. Being an advocate, is there ongoing programs or things that we can help support, or how do we move that forward when we go back home, basically? And that could be a take home, or just really curious on that.
I think what I was kind of getting at is that it's two-pronged. So I think you can advocate at your kind of system level, be it with the EMS providers. It's different depending where you live, how those services are dispersed. But I think if you're working with families, you can have them work directly with having the right meds at home and speaking with their local ambulance station. Like I've seen this work in some jurisdictions. Speak with the actual local ambulance station about what that child's going to need. It makes a big difference when the people that arrive with the ambulance are like familiar with the child and what they need. They can have documents at home, they can have meds at home. The other thing, something really, really cool that just happened in the province of Ontario is, because you were talking about families and advocacy and all this, a family of a girl with epilepsy has gone to the provincial legislature and advocated that teachers must be educated and able to give rescue medicines in schools. So it kind of goes along the same lines. So advocacy works. Thank you to those that advocate.
Thank you. Excellent session, Craig. Congratulations. One of the questions, I mean, it seems like really epilepsy affects mortality in all kinds of diseases. So the question is, what is the immunological effect of not only seizure activity, well, we know there are, but also of anti-seizure medications? And that's going to be, I think, may play an important role. I mean, we see that also, for example, with post-stroke epilepsy, that people with strokes and seizures, even though they may be controlled, have a much higher mortality rate or shorter duration than, for example, people just with strokes.
It's a very interesting question. And Dr. Hirsch, I think, has looked at some of the negative immune consequences of anti-seizure medication and found that as a whole that they may actually predispose people to higher rates of infection and maybe cause immunologic dysfunction. And so that the consequences, just like with accidents and injuries, the consequences of getting an infection if you have epilepsy or you're taking anti-seizure medication may be higher, even if you don't have some of these comorbidities. Anybody else comment?
Inflammation, hot topic.
I mean, I think I would probably just follow up and just advocate for, I think we need a lot of studies now looking at the adverse effects, but proactively dealing with those adverse effects. So for instance, if you've had a stroke, you're on enzyme-inducing anti-seizure medication, or if you're on valproic acid, say for instance, you have dyslipidemia as a result, should we be treating patients with statins? I mean, is this at a level of a cardiac risk factor that does require interventions at that level? Is things like aspirin and that sort of thing necessary in our patient population to prevent these types of deaths? Because in many respects, you could argue, as I mentioned, coming off the medications can be just as detrimental. So in terms of how to best manage the side effects of that, because this probably does contribute to some of that mortality. The other thing, of course, would be stigma as well. And I think, unfortunately, there's still a lot of stigma around epilepsy, and especially socioeconomic impacts of that. So I would imagine that does play into a lot of it as well, especially when we see post-stroke epilepsy and so on. I think that does actually impact things quite a bit. But from my own personal perspective, I think that we do need to start performing some randomized control trials looking at interventions for cardiac health routinely in patients with epilepsy.
Oh, we have somebody in the back. Sorry, go ahead. I get blinded by lights.
Thank you very much for an interesting session. Talking about comorbidities, talking about seizures and epilepsy, of course, reminds us that we're talking about whole person health. But I've yet to hear anybody talk about the role of family medicine in this problem. Are we ruling it out, or is there something that we should be doing in the community?
Can you hear me? No, so I think family medicine is super important. And I think that for me, the take home from what I was discussing is that most of the mortality in adults with epilepsy is probably or possibly not related to the epilepsy or is not primarily seizure related. And so there's a huge opportunity for primary care providers, whether it be family medicine or internal medicine or geriatrics, to really be reducing mortality for our patients. So I think family medicine has a huge role here, because the reason that most adults with epilepsy are dying are things like cardiovascular disease, which I agree we have some role to play. We're giving them these medications. Seizures themselves may also contribute, but certainly primary care providers are very qualified to help reduce, treat and reduce risk from cardiac disease. And similarly, there's, cancer mortality is also large in adults with epilepsy, and the screening and at least initial screening for that is primarily coming out of, primary care.
I mean, I think the problem lies, and I don't know what it's like in your center or in Canada, is access to primary care is getting harder and harder. There was something in the news recently that the Partners program in Boston stopped taking new primary care patients. So it's a large health system that you can't access primary care. And I know for my young adult patients with epilepsy, I'm really the only physician that they see on a regular basis. And a lot of that sort of primary care ends up falling on me, at least the screening part, cajoling them about their blood pressure, making sure they're getting age-appropriate screenings, checking cholesterol, vitamin D, all those things that normally primary care physicians would do, is maybe the role of the epileptologist, because there's no access.
Later in this meeting, I'm talking in another session about educating primary care providers about epilepsy. And I think one thing we see a lot, you probably see it too, is primary care physicians are a little nervous about taking on some of these patients who have so many complex
conditions. But if we can improve their knowledge of epilepsy and their comfort level, I'm not asking them to treat the epilepsy, they can treat the cardiovascular disease, but they need to be willing to have the person with epilepsy in their practice. So it's a great reminder from Dr. Smithson of the importance of primary care.
Okay, we have time for one more.
Hey, Dan.
Hi.
Yep.
Test.
Hi, nice to see some of you. Dan was my senior fellow. Real quick, one question about related to cardiac comorbidities. I had a patient when I was a fellow where the patient had asystole related to the seizures. We had a really difficult time trying to get cardiology to put in, a defibrillator, and sometimes it's not always clear what the association is, and cardiology will often say, oh, treat the epilepsy, which is obviously easier said than done. How would you guys address that in your practices, considering the patient that we had at Columbia ended up dying, actually on the telephone with his dad?
I mean, I think we've all had that experience.
Not with the dying.
No, sorry.
With the cardiologist.
Yes, with
cardiologist,
difficulty in getting cardiology to put in devices to reduce mortality. And they often say, well, it's because of the seizure and you should treat the seizure. But I think that's speaks again to sort of having good relationships with colleagues. And I think at some of the centers that I've worked at, it's been easier, and some centers it's harder, and it's usually a function of how closely cardiology and epilepsy work together and know each other, and that because some, as you said, some seizures are epilepsies are just really hard to treat, and it's not realistic to think that we can stop the seizures, and we don't want them to die because their heart stops. And I think in those cases, cardiology is usually willing to put devices in.
I think probably better data too. Most of our cardiologists come to us with small studies and say, well, there's asystole, but no one ever dies of it, so we're not going to do it. I mean, we see most of the asystoles, and they usually are fine afterward, which is fine, but these are very small, underpowered studies that they're using to back their own decisions there. So I would argue that, again, as someone that's interested in big data and population-based data, I think that's something that we actually need real hard data on to actually go back to them and say, well, no, actually, that's unacceptable. Yeah.
So I just wanted to add something from the patient caregiver perspective is that because there are so many comorbidities within epilepsy, that this is a huge issue across the board, not just between the neurology unit and the cardiology, but with pulmonology, and a lot of this ends up falling on the role of the caregiver or the patient to play quarterback with all of these specialists. And we have had issues where my daughter was scheduled for surgery, but the pulmonologist hadn't been notified. And then in a last minute emergency, somehow the pulmonologist finds out that the surgery is happening and doesn't approve of it. And it is a surgery that is at risk. That would have put my daughter at risk because she was not breathing well enough. This was very early on in our journey, and I had no idea that I needed to be the person responsible for coordinating all of these pieces. So this is a major systemic issue that puts our patients at risk when the different departments aren't working or connecting with each other. And it took us 3 different hospitals before I could find a hospital that would actually coordinate between all of the different specialties. So it can be really, really frustrating on the part and puts our patients at risk.
I think actually, sorry, just really quickly, that's a really important point. Yeah. And yeah, I think that's a really important point, because to the comment about primary care physicians, we actually tried to have a CME with a primary care physician. So they came to us and said, we are not interested because we are overwhelmed. Mm-hmm. We are absolutely overwhelmed dealing with everything else that's on the table right now. We simply do not have time for that. And I think absolutely there needs to be a whole system overview of this. Yeah.
Agree 100%. Well, I just want to thank the speakers again, and thank you guys for your attention and your thoughtful questions. We're going to take a 10-minute break after Gardner.
Yeah, thank you. That was excellent. Thanks, Dan, for moderating. Quickly, before we go to break, I just wanted to let everyone know that for all the speakers today, PAME was able to purchase Kelly's book, which just came out this month. It's beautiful, and all the families, we got one for them too. And so for those who aren't getting a book today, They're on Amazon, and I can attest to it's a fantastic book. So thank you all. And we're going to shorten break. Oh, sorry. And Cure has them at their table. We're going to shorten our break to just 10 minutes, please. I'm sorry we went over a little bit, but I invite you to have coffee outside. After coffee, we're going to have the 2 concurrent breakouts. The breakout room is next door, and that's going to be the brainstem's role in breathing. And in here, we'll be tackling hard conversations. Thank you.